Hello, I'm Bruce Sands. I'm the Division Chief for the Dr. Henry D. Janowitz Division of Gastroenterology at Mount Sinai Medical Center, and I'm pleased to join Dr. James Aisenberg, who is Clinical Professor of Medicine, also a member of our division. We've been invited by the editors of Gastrointestinal Endoscopy to discuss the study, The Detection of Premalignant Colon Polyps During Colonoscopy is Stable Throughout the Workday, which appears in the May issue of Gastrointestinal Endoscopy. Jamie, good afternoon. Let me ask you the first question. Why did you and your group undertake this study?
Thank you, Bruce. First of all, I'd just like to acknowledge Dr. Joey Friedman, who is a fourth-year medical student currently at Mount Sinai, who really did the bulk of this work when he took a scholarly year working here in our office. The year was funded by the Digestive Disease Research Foundation, which I'd also like to acknowledge, as well as all the nurses and physicians in our private practice where the research was actually conducted. So to answer your question, Bruce, we really undertook the study for two reasons. The first reason was in 2009 there were two studies that were published in the literature, one from Cleveland Clinic and one from the LA VA Hospital, both of which concluded that colonoscopy performed later in the workday detected fewer polyps than colonoscopy performed earlier in the workday. This implied that colonoscopies in the afternoon might be less preventative, less protective against colorectal cancer than colonoscopy performed in the morning. And the authors in both studies hypothesized that it was a cumulative fatigue effect related to performing back-to-back procedures over the course of the workday that was responsible. Now, this was sort of a catchy and plausible hypothesis, and it actually gained the attention of the lay press. So the New York Times or the Harvard Medical School Health Letter both published reports which were seen by readers around the world, lay readers around the world regarding this. And in fact, my practice here in New York, patients actually came in and they said, Dr. Aisenberg, is it okay I'm having my colonoscopy in the afternoon? Is that a good thing? Should I be having colonoscopy in the morning? So the other point was that even within our own profession, some of our thought leaders wrote editorials suggesting, well, maybe we should do colonoscopy in the morning and endoscopy in the afternoon. So clearly it was a subject that required further exploration. Now, in our practice, we actually, which is a group practice, we hypothesized that differences in conditions within colonoscopy or gastroenterology practice might mitigate these differences. So for example, differences in bowel preps, we only use split dose bowel preps, might mitigate this effect, or moderated procedure scheduling where we don't do as many procedures back to back might also make a difference. So we aimed basically to analyze the impact of time of day in our practice. The other reason that we undertook the study was that we had an interest in sessile serrated polyps. And as most of our readers will know, sessile serrated polyps are an alternate pathway to colorectal cancer and have been implicated in so-called interval carcinoma development as well as right-sided colorectal cancer development. And we thought that our database would be an excellent database to begin to understand during routine colonoscopy how commonly are SSPs detected and so forth. So those are really the two reasons we undertook the study.
Well, great. It's an interesting idea. Maybe you could tell us a little bit about the methods of the study. What did the patient population look like, and what were the primary outcome measures?
Great. So basically our practice is an office-based practice. We decided several years ago as a group that what we would do is divide the day into two, and a physician would have a block of 4 to 5 hours during the morning or the afternoon when they would do a colonoscopy and endoscopy intermixed, or they would see consults and do academic work or administrative work or whatever the other tasks were of the day. And we do this as a group. There are 4 of us. We do this 5 days a week when we're in town. We perform open access procedures as well as follow-up procedures, and we decided to also allot 45 minutes per colonoscopy procedure, which budgeted time both for the pre-procedure informed consent discussion, the procedure itself, and the post-procedure discussion of the results. We use routine white light colonoscopy, and for this study what we did was we have a database and we reviewed basically every patient who came in during the calendar year 2009 over 45 years of age who was eligible for surveillance or screening colonoscopy and who was endoscoped by one of 3 experienced colonoscopists. This yielded a population for the study of about 1,500 patients, and they were a typical colonoscopy screening population. They were about 60 years of age, 41% were male, 3/4 of them had screening exams, 1/4 had surveillance exams, and the average procedure length was about 20 minutes, and the mean withdrawal time was about 10 minutes. You asked about primary outcome measure. We chose to measure the detection rate for what we called pre-malignant polyps as a group, and that represented the sum of adenomatous polyps plus sessile serrated polyps. We thought those were the polyps that were the greatest, that was the outcome of greatest clinical importance. And we analyzed our outcome in 2 ways. We looked at hour by hour across the day, and we looked at a binary morning and afternoon analysis.
Great. Well, can you tell us a little bit about the results of the study? What did you find?
So, several things. First off, we were struck, we looked at bowel prep quality, and we think this may be quite important. We found that overall the bowel prep quality was really excellent. 98% of our preparations were what we called either good or excellent. So that represented a quality control which enabled us to detect polyps, we feel, at a high rate. And in fact, we found 47% of patients had at least one premalignant polyp, which broke out that 42% had an adenoma and 8% had at least one SSP. Now, in the primary analysis, we found that the detection of premalignant polyps and also of adenomas and SSPs in our practice conditions was independent of time of day. Now, this was true, this conclusion was upheld whether we looked in the hour-by-hour analysis or whether we looked in a binary morning and afternoon analysis. And in fact, we looked at each of the participating physicians individually, and the data was again upheld. And we looked at the riskier polyps, such as big polyps or high-grade dysplasia, or polyps that were on the right side, and again, the finding was upheld. We also performed a multivariate analysis, and we found only that male sex, previous history of polyps, and increasing age were risk factors.
Well, the results are exactly the opposite of what the LA VA and the Cleveland Clinic studies had found. So why do you think this is the case, Jamie?
Well, that's the question, and we didn't study this question directly. Our study was not designed to analyze that question. So in a way, the study is hypothesis generating rather than conclusive. Our hypotheses are, as I said before, that the use of split dose bowel preps, which are comparably good throughout the day, as opposed to single dose bowel prep given, say, at 5 p.m., as we all used to do years ago, allows for a high quality bowel prep that's uniformly good across the clock. In fact, in our group, what we do is we give the bowel prep, the second dose is given no more than 6 hours before the colonoscopy start time. Now, patients grumble about this sometimes, particularly those who have to get up at 2 in the morning, but generally speaking, if the patient has an explanation given, I think they understand. The other thing that we hypothesize, and it's purely hypothesis, is that scheduling may play an important role here. I mentioned before how we deliberately moderated our procedure scheduling into 45-minute colonoscopy slots and two blocks per day, and we would hypothesize that that gives us just a little bit of more time to recover between procedures, a little bit less of a tendency perhaps to rush or to be distracted or fatigued. We all know that colonoscopy is a very high demand commodity at the moment. We all know that colonoscopy is something that is demanding physically and visually, and we all know that production pressure, as it's been called, will only increase as reimbursement declines and so forth. We believe that for our group practice, moderating the schedule a little bit and trying to control it may have a role, but as I said before, this is not something that we study directly in this paper.